Hello, everyone, and welcome to our Vessel Health webinar series today. I'd like to thank you for joining us online for this very special educational live broadcast. My name is Emily Eberly with Sachs Communications, and I am your technical producer. It is my pleasure to welcome you to today's webinar, Troubleshooting Your Peripheral Arterial Catheter. Here's a big thank you also to Teleflex Medical, who is our sponsor for today's program. So welcome everyone. During our time together today, we'll focus on the arterial catheter troubleshooting techniques, performance, transducer setup, assessment criteria, and the importance of daily device calibration. Now, without any further ado, I'd like to welcome Rita Larson from Teleflex, who is our moderator today. Rita, I'm so glad to be working with you again. You're always a delight to work with, and this is a special session today. I want to thank you for all of your support in bringing this Teleflex webinar to so many people today. Are you ready to get started?
I'm ready, and thank you very much, Emily. As you said, it's always a pleasure to do this and always a pleasure to work with you. So good morning or afternoon, everyone, depending on whatever part of the world you're in. My name is Rita Larson, and I am a Senior Clinical Marketing Specialist at Teleflex Medical Incorporated. Following our presentation, as Emily said, we do welcome your questions. Please enter the questions on the questions section of the GoToWebinar panel. This webinar is accredited for 1 contact hour for nurses and respiratory therapists. The title of today's webinar is Troubleshooting Your Peripheral Arterial Catheter. And speaking on this very important topic is Amy Barden. Please let me introduce to you Amy. She's a friend of mine. She's a colleague. She has been a vascular access specialist with over 20 years of critical care and device insertion experience. Through this career, Ms. Barden has been on a vascular access team, inserting and educating on vascular device insertion, including arterial, central venous, hemodialysis, and IABP catheters. Amy believes that all patients deserve a no blind stick approach when vascular access is required. Today, Amy shares her knowledge and passion with clinicians around the world as an international speaker and by developing vascular access curriculum and overseeing simulation training courses for both physicians and non-physician clinicians. Amy wishes to disclose the following. She is an employee of Teleflex Incorporated. Many of you asked this question in the beginning, and I will go through it in a little more detail. This activity has been approved for 1 contact hour of CRCE and C&E by the AARC and California Board of Nursing and the Florida Board of Nursing. At the end of this webinar, you can obtain those continuing education credits by logging on to the URL link provided. Please complete the post-test and the evaluation form. Upon successful submission, you will be able to print your certificate of completion. Accreditation is both for respiratory therapists and RNs. Now, with no further ado, I would like to introduce you to my friend and colleague, Amy Barden Spencer. And Amy, I'll turn this over to you. Thank you for joining us today and sharing your knowledge.
Thank you, Rita, for that great introduction. And thank you for everybody that's attending today, whether you're at work in the hospital or you're sitting in your department and able to do this over your lunch, and or whether you're at home spending your personal time with me. So I thank you for this information that I'm about to share with you. So the learning objectives for today's program are really to discuss catheter insertion techniques that aid in catheter performance, because one of the biggest troubleshooting opportunities really is to make sure our catheters are placed in the right location of the insertion area that we select, and that really is based on assessment. The next one really is to describe the transducer setup and the add-on devices that impact catheter performance, because remember, arterial catheters are that one device that have to be attached to something else, or else the patient has arterial bleeding occurring. So we always have to be prepared, and those add-on devices matter. The next one really is to identify the daily assessment criteria for indwelling catheters. Regardless of the catheter type, somebody should be assigned, whether it's the respiratory team if they're placing the device, whether it's the nursing team if they're placing the device, or even the physician team. Somebody should be agnostically looking at the device, the performance, and also the extremity in which the catheter is in situ to make sure that we're optimizing the performance of the catheter, but also optimizing the metrics that we receive from the catheter. And the last one really is to discuss the importance of daily device calibration. Like I said before, we have to transduce or connect the arterial catheter, regardless of the insertion site, to a monitor. And this monitor requires calibration. And so there's the transducer tubing that's connected to it. And by doing this, we can make sure that our blood pressures are as accurate as possible when the catheter is indwelling. So just from an overview for arterial catheters, we have used them for a really long time. Arterial catheter insertion is very common. We use them in critically ill patients. And just think about your own practice today. You're on this webinar because you use an arterial catheter, you're aware of them, or you've had issues with them. And we place these in most critically ill patients who require blood sampling, blood pressure monitoring, or potentially that are on a ventilator, because we're doing serial sampling or continuous titration of blood pressure and medications. Arterial catheters dwell for a long period of time because they're not removed until clinically indicated. So depending on your hospital policy and procedure, you may change them routinely, which is not recommended, or you may allow them to dwell with good assessment and remove them when no longer warranted, and that really should be the best practice. Arterial catheters do have an associated risk, and we should remove them if they do not function. And I'm going to talk throughout the webinar about functioning and non-functioning devices, and that we don't leave devices in an idle opportunity just because we need a blood sample. If it's not functioning to the full breadth and depth of its ability, the catheter really should be removed. The pressure transducer is required for blood pressure monitoring, and it's actually required regardless of where the arterial catheter comes from. So in my own practice, I receive patients from cath lab on a daily basis who had a sheath in the groin that had to be monitored before the sheath could be removed. And this is very, very important in your own practice, that when an arterial catheter is in place, regardless of where it is, whether it's the radial, the brachial, the femoral, it has to be monitored, because one simple stopcock being moved to the on position could allow blood loss to the patient. And we need the monitor and the transducer hooked up to allow for the alarm process to give us those clinical indications or those alarm indications within the critical care areas. And the last one really is securement and the flush solution. We're going to talk about securement because we've advanced through securement. It's no longer a recommendation to suture an arterial catheter. And if I could see each of your faces right now, you're like, really? We do not suture arterial catheters. We do not add any more needle sticks to increase risk of infection. Is there a population that we have to? Absolutely. Should we do it every day? Absolutely not. And the flush solution is also something we're going to talk about because it really impacts the dwell of the catheter. So in the United States, we have moved to a saline flush. And think about your practice again. Do you use saline in your bag, or do you use heparinized saline in your bag for your pressure transducer? There is evidence that shows that using heparinized saline extends the dwell and the life of the catheter, keeping the internal portion of the catheter cleaner over a longer period of time. In the pediatric world, we still use heparin. In the adult world, we have sort of phased heparin out and we only use saline. So again, just think about your practice, and that might be a question that you ask me in the end based on your own practices in your hospital. So we're going to start with a pressure transducer, because no catheter, arterial catheter especially, can dwell without a pressure transducer connected to it. It is an essential component for catheter use. It allows us to draw blood, to transduce blood pressure, but it also adds opportunity for you to be more knowledgeable when troubleshooting, especially when your blood pressure may not correlate with your blood pressure that's shown on the cuff from a non-invasive point of view. Assembly and preparation of this setup is in an aseptic manner because this setup actually attaches to the patient during the sterile procedure and dwells for 4 days. And if the catheter connection is, if there's risk of contamination or infection, then that goes right up the catheter body into the bloodstream. And that would be a catheter-related bloodstream infection related to an add-on component. So very, very important. So I'm going to ask you again, who's making your transducer setup? Is it made for you? Do you burp your bag to make sure there's no air in that setup? And who does the sterile connection when that arterial catheter is placed in your patient? Is it you, or is it somebody that puts their hand into your field and attaches that setup for you? The transducer also regulates flush solution. The flush solution required to maintain arterial catheter patency is 2 cc's an hour. So another thought, a little nugget, would be, do you use a 1,000 cc bag or do you use a 500 cc bag? Because over time, every day, every hour that arterial catheter is connected to a pressure transducer, it is given a 2 cc flush, and that 2 cc maintains patency within the tubing and within the catheter. And if your bag runs low or the pressure in the bag is reduced, then you get a dampened or sort of an occlusion type formation within the catheter body, and we're going to talk about that in great length when we get to the troubleshooting section. The other one that really maintains from a patency and to ensure that 2 cc actually occurs, and remember that 2 cc's an hour for that bag volume of 500 cc's that's left hanging for 4 days, does not include any flushing that occurs when you do blood sampling. So always consider how much blood sampling are you doing and how much flushing are you doing, because you should be assessing the bag volume every shift to make sure that, one, the pressure is at 300 millimeters of mercury to make sure that the pressure is sustained in the bag, but also that the bag actually has volume of solution in it for the flushing maneuver. It is changed every 4 days or per hospital policy. That is the actual recommendation from INS now, is that it's changed every 4 days. And it's connected to the monitor and displays a blood pressure waveform. And we're going to talk about when you connect the monitor and don't have a waveform, or maybe when you have a waveform that doesn't reflect what the pressure is reflected in another device. So we'll go through that as we move forward through the slide deck. So these are examples of your pressure transducer. And I'm going to talk about these throughout the presentation. So I just wanted to make sure that you knew exactly what I was talking about. So up on the top corner where it looks like there's a plunger apparatus, that's called a vamp setup. And what a vamp does, it allows you to aspirate waste into a closed chamber. When you aspirate waste into a closed chamber, this is required anytime you do a blood sample. Then what happens is you remove the blood sample after turning the waste chamber to the off position and aspirate out of the little plunger, the little yellow plunger there that's just distal to the waste chamber. Then, after drawing your blood sample, you give the patient the blood back. This is very important if you think about blood conservation and the fact that we don't give a lot of blood anymore. So, whenever possible, we need to give in a closed environment, closed system, one from infection reduction and also from blood wasting. We really need to use those type of devices. So do you use it? And I would like you to ask yourself why you wouldn't if you don't use it. On the right-hand side, all the way over to the right-hand side, is a different apparatus. Again, it's in a closed system. It's a little different type of transducer. It has a blood waste chamber, and then the blood, again, is given back to the patient. There are no disconnections and reconnections because doing that adds risk to the procedure, but more so to the patient from an infection prevention standpoint. In the middle, there is the pressure transducer bag. And when I refer to the bag needing to be inflated or the bag hanging, that is what I'm referring to. So you'll, just to give you some visuals since I'm not standing in front of you and can't see your faces. The bottom corner is the transducer, and that's where you level and zero. And you see the little blue pulley that's right next to the cable connection? That is when I say this needs to be leveled to phlebostatic access. That is the area in which needs to be leveled in that region. Not the vamp, not the bag, not the tubing. But just right there where it has a little blue pulley, that is actually the transducer. That is where they measure the blood pressure, and that's what should be leveled when I refer to that in later slides. And then over to the right are the cables that are required to connect. So you put the A-line in, you have the transducer connected to the A-line, and then you have to actually connect the transducer to the monitor. And each monitor is unique, and as each transducer setup uses a unique cable configuration for your arterial catheter transducing. So please be very familiar with each of these items in your own hospital, but also as we move forward through this presentation. So when you think about troubleshooting the transducer setup, this is really important because when I put an arterial catheter in, I want it to work right away. So I'm just going to walk through some of the problems and some of the solutions for you. So if catheter occlusion is occurring, if I could have you virtually raise your hands, I'd see you raising your hands all over the United States and beyond. And you really have to ask yourself, why is the catheter becoming occluded? And the first thing that I really want you to do is go back to the pressure transducer bag. Is it inflated to 300 millimeters of mercury? Who's responsible for doing that? And how often is that being checked? And if you work beyond the pediatric world and you work in the adult world, and you have removed heparin from your bags, and you have patients that have a high thrombotic occlusion rate or a high platelet count, it would be interesting, to see if you can move them by not doing everybody's saline, but also by adding heparin back into those high-risk patients. And that's really how we should use heparin as a strategy. Now, if your issue is that you don't have a waveform, you've connected the transducer, you've connected your arterial catheter, you have good blood return, but you don't have a waveform, there's just a couple of things that you really need to check. One, is the stopcock turned off? Is it in the off position? In many cases, we have it in the off position before we connect the transducer. And another opportunity would be, is the transducer disconnected? So is the cable actually connected to the monitor? That is very, very important. And the last one really is, if you don't have a waveform, but you might have a waveform, but you don't have a pressure reading on the waveform, you want to look to make sure you've leveled and zeroed, because even once you connect the monitor requires that you identify what type, that you've recognized the transducer by zeroing it to phlebostatic access and atmospheric air. So just little tips from a transducer perspective. If you have repeat catheter occlusion, I really would enhance the thought process to add heparin and track the patient demographics where that's occurring. And I also want you to look at the insertion location, as we're going to review that in a couple more slides, and how that might be impactful. If you have a dampened wave, people say, Amy, what is a dampened wave? If you have a dampened wave, it means you don't have a crisp dichrotic notch and a nice upslope within your blood pressure wave. And if this is the case, there's a few things that I want you to do. I want you to ensure that your tubing is primed fully. And if you use a VAMP system, that you've also primed that as well. I want you to ensure that there is no air bubbles within the circuit, because if you're not priming and burping your own tubing, you may have air residual that's sitting within the circuit. You need to disconnect or open the most most proximal stopcock, and bleed the system out. Just flush it with saline and get all those extra bubbles out if there's anything, any of those present. Another option really is where's the position of the catheter? And again, I'm going to keep saying that. I'm probably going to sound like a broken record, but position of the catheter is so, so important, and we're going to go through that when we would look at insertion site selection. The next one's catheter dislodgement. And catheter dislodgement happens because, one, we don't secure the catheter. Two, maybe our patient's combative. Three, if you're a respiratory therapist, the first thing our patients like to do when they wake up from anesthesia is try to pull their ET tube out, and they reach up and they flex their wrist. That causes catheter dislodgement. The biggest thing that I want you to take away from this lecture today is putting the tubing around the thumb. In practice, if you think about when you send a patient to the OR, what do? We take their jewelry off and we give it to their family. And we do that because we know that we are going to give them fluid, they're going to have fluid shifts, and they're going to swell. So why, if you're one of these people or one of these facilities that put it around their thumb, would we do that in practice? Patients can manipulate their wrist. It feels like you have flip-flops on between your thumb, between your big toe and your middle toe, and they are annoyed by that feeling. So all they do is continue to play with their wrist, and that dislodges the catheter. So we really have to be simple in our mindset of where we put the tubing and how we dress the catheter. And the last one really is blood in the pressure line. We have to make sure the bag is inflated, and that after each time we do a blood draw, that we flush the catheter effectively. Over time, that will cause transducer problems. So when you connect to the monitor, it's very, very important that the tubing is totally flushed, all air is removed, and that the bag is at 300 millimeters of mercury. In the illustration, you see where the transducer is level with the phlebostatic access. You really want to try to level this when the patient is closest to flat as possible. As you sit the patient up, they sort of lose that phlebostatic access mark. And by measuring to phlebostatic access, it just means myself, yourself, and the person following you is going to measure that blood pressure to the same area. And that area is specific to the right atrium of the heart. It's also important that we aseptically connect the tubing, because if we don't, the tubing then has that increased risk of infection and doesn't add any value to the catheter dwell time. And I added a couple different pictures of some devices that we add in practice, because if you think about when you connect to the tubing and connect to the monitor, the tubing has to be changed every 4 days, as I said before, but dressings get changed every 7. So if I'm asking you as the inserter or the care and maintenance clinician to change the tubing and not the dressing, you actually have to break the dressing down to get to the tubing connection. So what we do is we add a 6-inch piece of high-pressure tubing, and it has to be high-pressure tubing because it's the arterial system, and a one-way stopcock. And I want you to focus on this one-way stopcock for just a second. This one-way stopcock connects the tubing to the transducer tubing. The tubing connects to the arterial catheter that's indwelling in the patient. And for me as an inserter, this allows me to dump these 2 sterile components on my sterile field and sterilely attach my tubing and then hand off that one-way stopcock to the person waiting with the transducer. This also allows the cycle time of transducers to be changed at every 4 days without breaching my dressing or having to go down to the insertion site to change the tubing. So this is an arterial catheter site. So you see where the catheter is in place in the radial. It's about 1 finger below the ulnar arch. It's distal to the thumb. You can see that there. You see the one-way stopcock slightly and a little bit of blood in the tubing. So for me, I would flush that tubing to make sure there was no visible blood. But by having this stopcock in line with the pressure transducer tubing, I'm actually able to turn the line off, aseptically disconnect, and reconnect a new transducer to this without actually interfering with the integrity of the dressing or the securement of the catheter. So when you think about connecting to the monitor, there's a few things that are really, really important. And arterial, if the problem really refers to the blood pressure not correlating, I really want you to think about this. So the last time you were called to the ICU or the last time you had a patient and the blood pressure cuff did not match the blood pressure on the arterial catheter. It's very important in your practice that you decipher that an indwelling arterial catheter with a good waveform is the most accurate blood pressure within that extremity. So the first thing I want you to do is look at the patient. You always start with the patient. Then you walk through the transducer and walk back to the monitor. So is the transducer level in 0? Does the arterial catheter give you a blood return? What is the blood pressure reading, and is the transducer positioned correctly? The next thing I really want you to think about is the state of the patient. If the patient is septic or in septic shock and is constricting peripherally, and you'll know this because in the assessment of their hands or extremities and capillary refill, the catheter is actually telling you what the true blood pressure is in that extremity. If you have patients that have this septic picture, the best insertion location really is femoral, because remember what the body's doing. It's the compensatory response to constrict and just shunt blood to the torso area and to the trunk. And that allows femoral to give you a more accurate blood pressure. If you're going up on medications and unable to titrate, you really need to, 1, change location, assess the medications to make sure we're not giving too many because we haven't given enough volume related, and then check to make sure you're level in 0 with the transducer. If your transducer is too high above phlebostatic access, your blood pressure is reflected lower on your waveform. If your transducer is low, below the phlebostatic access, your blood pressure is really reflected higher. This is so important because we titrate medications to such a very small mean arterial pressure. So please use one source or the other, and if your arterial catheter is not meeting your needs, remove it because it does add risk. So catheter occlusion is the next one. This is repeats over time, and we really need to maintain that bag pressure to make sure we're flushing well. If you have no waveform, again, you're going to look at the transducer, you're going to zero it, you're going to look at your stopcock, and you're going to walk back all the tubing connections to make sure you're on and every connection's on. Sometimes when the transducer is mounted to the arm, things get tucked under sheets and patients roll over on them. So just make sure you're always checking to make sure the tubing is totally open. And another one is when we transport our patients, we like to take the rollerball clamp and push the tubing down. So when you take the rollerball clamp and close the tubing because we don't want any continuous flow, we actually stop flow to maintain catheter patency, and then we have an occlusion. We connect to the monitor, we don't get blood return, and we're trying to troubleshoot. So also think about what you did last with the patient when you're trying to troubleshoot the problem you have right now. You're always going to make sure you're level and zero for your transducer. Remember that mean is very tight. And then dampened waveform, again, removing any air from the system and making sure your bag is inflated to 300 millimeters of mercury. So catheter dwell time is really specific to the hospital and what metrics that you're tracking. And in today's day, you should be tracking arterial catheter infection rates. And those infection rates and those practices will help you control your clinically indicated line change and or to remove lines when no longer clinically indicated for use. Arterial catheters by the CDC and any other association is not recommended for routine changing unless there is a mechanical problem with the catheter itself. And for an arterial catheter, if you recognize that it's occluded, you would not overwire, because if you had a thrombosis at the tip of your catheter, you have to think about where that wire would move that thrombosis during your catheter exchange. And then catheter dwell is really evidence to be extended with use of heparin in the solution bag. So some insertion practices really are, the radial is this first site of choice when you place a catheter. It is superficial, it's easy to palpate. We really should be using ultrasound in this state and age. From an infection reduction opportunity, we use chlorhexidine and we prep the area, and we use sterile drapes to make sure that the integrity of the prepping and the insertion and the inserter are all maintained. We do use an arterial bundle, and we also use an arterial checklist. This is a very, very important line, and these lines dwell within our ICU patient population, and anything that we can do to reduce risk and increase performance of these devices is really optimal. So when you think about catheter dwelling, over time, we might not be able to get blood return. And if that is the case, I want you to think about a couple different scenarios. So on your last catheter, on your last arterial catheter that you were called to the bedside for, and you were called to the bedside because they couldn't get blood. You were trying to do a blood sample and you just couldn't get it. But you looked up at the monitor and they had a great waveform. You have to understand that anatomically, if the catheter becomes dislodged from the artery, but sits next to the artery and has transient pulsatility, you're still going to get a waveform. So much so, if the next time you make a transducer setup and you connect it to the monitor, go ahead and zero it, and then just whip that transducer up and down, up and down, up and down. You can make your own arterial waveform. That's how sensitive the transducer is to reflect your blood pressure. But also, we as clinicians need to be very assessment oriented to make sure the catheter is actually dwelling within the vessel. If you have a waveform without blood aspiration, you really have to think, the last time this occurred, or maybe it hasn't occurred for you yet, but when you remove the arterial catheter, you're going to be holding pressure and you're going to lift up your fingers and realize, oh, there's no blood return, because the catheter may have very well been outside the space against the arterial wall and it was just transient pulsatility. Catheter occlusion is, I hear about this a lot, and you have to think about mechanical occlusion, meaning the patient's, it's at their wrist, right at the bend of their wrist, and it's not really down further where it should be. The patient flexes their hand in, just doing that one time, and or maybe if they're restrained and they're going for something, because remember who these lines are in, we impact the performance and the occlusion rate just mechanically with range of motion and movement. And the other one that's really important for us to understand from a catheter dwell point of view is infection. And we should be tracking it, as I said earlier. And there's a few things that we can do that we've done through all other vascular access devices to reduce the risk of infection. And one is catheter pistoning. So if you just think about pistoning is the movement of a clean and a dirty piece of tubing in and out of the insertion site, in, out, in, out. This normally happens when the catheters, one, are not secured appropriately, have a large external segment, meaning they're hanging out further than they should be outside the exit site, or they aren't well dressed, and the catheter can actually freely move. And when this occurs, the catheter goes in and out, and it's clean, dirty, clean, dirty. Then what happens is the bacteria from the skin outside the catheter insertion area migrates over the body of the catheter and transcends into the bloodstream. So very important that we keep our catheter secure and maintained at the exit location without a lot of movement. And I'm not saying to put an arm board on the patient. I'm saying to make sure your catheter is stable. The next one really is to consider removing the catheter if you think there are signs and symptoms of an infection. Anytime you do a pan culture, and when I say pan culture, I mean you're looking for an infection, whether it's the central line, an arterial line, a urinary catheter, any other catheter that we've placed in a patient that's in a hospital, we should also consider the arterial catheter. Because in the intensive care area and in the OR area, the arterial catheter is the most manipulated line within the hospital. So very important how many hands touch the catheter, how many hands touch the tubing, and how many people are accessing and deaccessing it for blood draws, transducer, leveling and zeroing, and even insertion. And the last one really is the maintenance bundle. So I'll ask you this, each of you. Do you insert the arterial catheter? And if you just said yes, are you monitoring and maintaining it to make sure that when it's no longer clinically indicated that it's removed? Because that is our best strategy to reduce risk of infection, is not to have idle lines or just-in-case lines. So when you think about the square wave and reading an arterial waveform, this is probably the most critical component to make sure that our blood pressure readings are accurate. So really a square wave is that one test that you're going to do once a shift to make sure your catheter is accurate, and you're going to do this in a few different steps. So a square wave is when you flush the arterial catheter and you're going to pull on that little blue thing that I showed you on the first couple slides, and you're going to observe on the monitor. So just like I show you in the illustration here, when you pull and you flush, you should have a perfect square wave, upslope, across, and downslope within 1 to 2 oscillations. A square wave test checks the dynamic response, so it checks the entire system pathway to make sure there's no kinks within the system. Because remember, kinking adds to dampened waves. It is extremely important too, I guess, to make sure that we have that very nice, high-quality square wave test. So in your daily documentation, you should be doing your assessment of the extremity and the pulses, but also your square wave test is appropriate and intact. So if you think about an optimally dampened wave, this is really a normal wave that you're going to see when you do your fast flush system check. You're going to have a sharp upstroke, you're going to have the terminate of the flat line, you're going to go across like a box, and you're going to have follow an immediate downstroke with a baseline of 0.12 seconds. This is a rapid return to baseline. It should not be a slow and steady return, but very much a rapid return to baseline. And you should also see a dichrotic notch. You'll see a very specific dichrotic notch within the waveform itself. So if you think about over-dampened waveforms, we have these two, and it's not a real crisp, a real sharp waveform. And this is my caution to you. My caution to you is to make sure that the scale on your monitor is actually scaled for the blood pressure. Because I have been called to ICU several times, or even to the OR, and said, my A-line is not good. My A-line is just not performing. And all I have to do is go to the monitor, optimize the scale. It doesn't change the waveform, but it sharpens the image. So really make sure, most hospitals set their scale from 0 to 300. My patients don't walk around with a blood pressure of 300. So if you change your optimal scale, it pulls your baseline up a little, it pulls your systolic down a little, and you actually have a really nice waveform there. And that's the first part of troubleshooting that I really want you to do when you have an over-dampened wave. And this occurs when activation of the fast flush generates the slurred upstroke and downstroke, and you don't have a real defined wave. This leads to an underestimation of the systolic and the diastolic because it brings both of those parameters closer together, and you really can't see a dichrotic notch. I want to troubleshoot this one immediately. It may need an arm board. It may need the tubing to be flushed. The catheter might be kinked because this looks like a mechanical occlusion to me. And if the catheter is no longer clinically indicated, I'm not going to do any of those things. I'm just going to remove the device. So if you think about the underdamped wave, this is probably more of what I see, especially when I receive a patient from the cath lab and they're on a balloon pump and I'm getting them back to the ICU and I'm going to put an arterial catheter in them. I may or may not have used ultrasound, but I know in today's world I'm going to, because this is all about how the catheter was placed or the patient's situation when the catheter is indwelling. So an underdamped wave occurs when activation of the fast flush generates a waveform that is characterized by numerous, like more than 3 at least, amplified auscultations. It really has a sharp upstroke and is repetitive. So overestimation occurs of the systolic and underestimation of the diastolic. So it really is a peak and drop, peak and drop, peak and drop. And this really relates to a false high or low blood pressure reading. So you really want to troubleshoot this one, optimize your scale again, make sure that look at your patient scenario. And some of the possible things that can be fixed with this, or maybe some solutions that you have to wait on over time, is one, you're going to remove the excessive tubing or multiple stopcocks from the system. So let me go back a minute just to the OR. When I'm in the OR with a balloon pump or an arterial catheter and I'm on the opposite side of the bed, I like extension tubing to be added into my system. When you get your patient back to the ICU, you want to get rid of all excessive tubing. The excessive tubing causes problems within the circuit, but it doesn't add any value. It did add value when I was in the OR and I couldn't reach the transducer, but once you get outside the operating theater, you really want to get all the excessive tubing out. And the other one that really causes this to occur is when the patient has tachycardia and if they have a high cardiac output. So if you have a patient scenario that correlates to either of those, this may be the wave that you're seeing, and this isn't something that you can correct. You have to let it correct itself over time, through medication or controlling of the symptoms that are making it occur. So from a waveform accuracy point of view, an arterial blood pressure reading really needs to be a crisp wave. We have to see a nice upslope. We have to be able to visibly see the dicrotic notch, and a sharp downslope. It really is the if you think about a non-invasive blood pressure cuff that just goes up every few minutes or an hour, every 2 hours, comes back down and gives you your blood pressure, or when you're actually looking at a waveform continuously and titrating medications, it's so important because this gives us instantaneous feedback, and the waveform really needs to be accurate. A catheter whip, and you might be looking ahead at the slide a little bit, and catheter whip, people say, hey, how do I get rid of this catheter whip? Well, I'm going to tell you, you change your insertion technique, because really catheter whip is caused when we don't numb the patient prior to catheter insertion, we place the catheter too low, we shock the vessel by putting the catheter in by not preparing it, letting it know we're coming by that numbing medication and preparing the patient if they're anxious. And whip is caused by vessel spasm, and it goes away over time. And you'll have whip, and you'll see that through the underdamped wave, but you'll have a sharp upstroke and a medium downslope, and then it will resolve itself over time. Sometimes a warm compress will help over the insertion site after the dressing's applied, just to maintain your aseptic area there. The catheter overdampen also can be caused by mechanical occlusion or underinflated pressure bag. So you hear my repeat offense of the pressure bag, so it's very, very important that we maintain observation of the system itself. So when you think about the waveform, if you have no waveform, you're going to look at the monitor, you're going to level in 0, and you're going to follow it back to the patient to and from. If your waveform is positional, I really want you to look, when I say positional, I mean you grab the arm and you look, you assess, you flex the wrist back, and wow, the waveform's beautiful. That is a mechanical problem. So you really want to consider moving your insertion site, maybe not on that patient, but on your next patient, please, lower. So what you're going to do is, if each of you could grab your wrist and look down at your wrist and see where your watch band is, and if you don't have a watch, it's okay. Put 2 fingers against the wrist where your wrist arches forward, and now bend your hand towards you. So 2 fingers below where your watch band is, that's really where we should be placing arterial catheters. We should not be placing them right at the base of the thumb where the thumb meets the wrist. So the last one really is a poor square wave test. You really want to consider an arm board, because if you think back to 2 slides, that is due to mechanical catheter failure. and that we are mechanically occluding the catheter with range of motion or insertion area. So if you have this issue in a catheter that's already inserted, please use an arm board. And you want to make sure you use the arm board in the appropriate manner. So the importance of leveling and zeroing, I go back to this because mean arterial pressure and titrating of medications is so important. So leveling and zeroing the arterial catheter is something that we have to do every day, and most hospitals do it every 8 hours. The frequency is determined by the hospital policy, but no, the more you do it, the better it is, especially if you're titrating medications. And you really only have to re-level when the patient moves position, but you have to re-zero at least every 8 hours. The transducer is aseptically open to atmospheric air. So I want you to think about this for a second. All of you that level and zero your arterial catheter. So I'm entering the patient's room. Hi, Mr. Jones. Hi to his family. I go to the pressure transducer. I look down. I turn the stopcock up to the upward position. I open it to air. I put the cap in my hand. You know that's what we do. I reach back to the monitor. I zero the transducer on the monitor. I come back to the transducer. I turn my stopcock back to the on position, and I put my cap back on. In a perfect world, what we should be doing is anytime we remove a cap from a system, a new sterile cap is placed. We never would put something in our hand, touch a dirty monitor, come back to the transducer, and then recap. So please make sure that you're influencing risk reduction through clean cap changes every time you open or close a system. So when you do level and zero, there's a few things that we should be thinking about. If you have the no waveform, you're gonna remember this for the rest of the year at least. I've said it so many times today. No waveform with a pressure trace. If you have a great pressure trace on the monitor, that means your cable's connected, but that means you didn't take the next step and zero the transducer so that it could actuate itself to the transducer. You also need to remember that if you have an arterial catheter that dwells over time, products aren't perfect. And if you have a transducer that just doesn't seem correct, that something you can't get a nice crisp waveform or it just doesn't resemble the patient picture, change the transducer. I've had to do it about 5 times in my career, but that was the fix. That was absolutely the fix. Make a new setup, bleed your transducer, prime it, flush it, disconnect and reconnect, and you're going to connect to that stopcock. Okay, that's what that allows that for. The last one on this slide is the invasive blood pressure that doesn't correlate. I already went through this with you, but I really want you to consider, we have lots of sepsis patients that come in now. We have lots of patients who treat themselves as long as they can, and then they come in critically ill. We are chasing our tail to make sure that we are giving enough blood pressure medication to support a very low blood pressure. We don't give a lot of volume anymore when we volume resuscitate patients. And it's very, very important that we consider what's happening at the insertion area. If your hand is blue, cold, clammy, with no capillary refill, and you don't have great distal pulses from the insertion area, you really need to get that catheter into a better perfusing area, because the other thing that can occur is total arterial occlusion when you remove the catheter or even when the catheter is still in situ. So when you think about insertion, and I talked about moving the insertion site out of the range of motion area. So you see the wrist on the screen, you see the tubing, it's not wrapped over the thumb, it's wrapped towards the thumb, which is very different than being wrapped over the thumb. It is 2 centimeters or 2 fingers below the range of motion area, so the patient doesn't really require an arm board, which is fantastic. So from an arterial perspective, it's easy to palpate, it's superficial, and you should really be using ultrasound for insertion. And I know that a lot of you are like, I don't need ultrasound. I could feel the pulse. I've never needed ultrasound. But I want you to take it a step further. And I want you to be a better vascular access specialist, respiratory therapist, or a nurse, and think about the assessment opportunity that you can have using an ultrasound and visualizing what you're doing during that insertion. The next one really is to check the capillary refill. We do this all the time, and we should be doing it with every extremity that has an arterial catheter in place. This is even as important to do it in the groin when you have a groin line in place, a femoral line, to check distal pulses of the feet of the affected side and compare those to distal pulses of the opposite side. Is it cold? Does it have good capillary refill? Because you should be justifying circulation from one extremity to the other. So if they have a femoral line in, it's pedal and it is distal in the feet. And if it is a radial or a brachial line in, it's distal to that insertion site. You see my no looping the pressure tubing over the thumb. I keep reminding you of that. Remember, if you want to practice this and you think that, you know, Amy's like, don't put that tubing over the thumb. If you remember anything, please remember this. Put the tubing over your own thumb. See how it feels, for one, to be the patient. Also, though, see how much you can manipulate the catheter location by moving your thumb slightly. It is amazing how much catheter dislodgement occurs because of the way we dress lines. All right, yes, those are my hands. So on this slide, it really is, I'm showing you the insertion zone. So you see just below the thumb there, where the arrow is pointing down, I do not want you to insert in an area of flexion or motion. So in one of the images, you have both of my hands, it says no range of motion. By putting the catheter in that location, you're not allowing the patient to move, do any self-care, do anything, any of their own care in the hospital. And every time they move their hand, the catheter moves. So please, please, please make sure that if anything, you just look at this diagram and you move down. 2 fingers or where the watch band is a great rule to think about. And the arm board. So I'm not a big fan of arm boards, and that's just me personally. I believe an arm board is a restraint, and I think that by moving the position to a better insertion area, you can actually remove the arm board. If you walk through your ICU today and you're like, wow, we use arm boards on everybody. If that's what you're doing, it's really an opportunity to move the insertion location to potentiate longer catheter dwell, but also reduce mechanical failure and make sure your catheters are very crisp and clear. So no arm board unless absolutely through troubleshooting you've identified a need for one. It should not be automatic. So if you think about the radial catheter dislodgement with looping over the thumb, poor capillary refill because you've taken too much space within the vessel and now they're constricted and now potentially they don't have enough flow around, so you don't have good capillary refill. If their hands are cold versus warm, you really need to think about, does the catheter need to stay? We're getting to an area that potentially we have an occlusion. Does that catheter need to be in place? Multiple insertion attempts is no longer acceptable. By evidence and by standard, as disciplines of respiratory therapists and nursing, we have 2 attempts to get a line in place. We should be using ultrasound and using a no blind stick approach on everything that we do. And then the last one is an inappropriate circulation with an Allen's test. It is our requirement that we do an Allen's test to make sure that we have collateral circulation prior to placing a radial catheter or doing a blood gas sample. It should be documented and well noted, and we should not place in any compromised circulatory area. We should move to the opposite side and never go above to a brachial area if we've identified that the radial does not have good circulation. So from a best practice standpoint, there's my loop thumb. See that over the thumb? Look, as soon as he bends his hand, that's going to bend forward and kink that line. Also, the catheter is going to piston because it's not actually quite in all the way. You can see a lot of catheter hanging out. And on the opposite one, the catheter, the tubing again is over the thumb, but look at the fingers. So if you walk into a room, your blood pressure doesn't match your cuff, they're telling you to fix your blood pressure, your waveform's not that great, and those are the fingers that you see, you really need to move positions and get out of that. Think about volume resuscitation. Think about how much inotrope and vasopressin and medications that we're on to support this blood pressure, and see what can be titrated to optimize circulation in that extremity. Very, very, very important. All right, there's my arm board. I'm going to tell you, only use it when you have to. Make sure that the catheter is inserted outside the range of motion area, and that's how the arm board should be put on. We should not have the arm board facing forward, and when I go through hospitals and talk to them and look at their arm boards, a lot of times the arm boards are placed on the opposite direction. So please make sure it's clean, dry, and intact, and there's no blood sitting between the two. Patients tend to sweat when they're on have an arm board, so please make sure that you're assessing the arm board in your daily maintenance. And then the last one really to review is the daily assessment. So one, do we need to maintain, does it need to stay in? Is it still clinically relevant? 2, is the site good? Is there redness, swelling, drainage? Does it look like it's getting infected? The line needs to come out. If it's warm with great capillary refill, good pulses, and the insertion site looks fantastic, that catheter can dwell as long as it's clinically indicated and you're utilizing it. The transducer assessment, where is it? Where's the pressure transducer located? Is it level with the phlebostatic access? Is the pressure bag inflated? Is there enough solution in the in the bag to maintain at 2 cc's of volume? And really, does it does the arm board, when you think of all the way to the arm board, does it restrict the patient movement? Does it restrict their circulation? And is it clean and dry? We really should be assessing the entire picture to make sure we're optimizing catheter performance. So when you think about dressings and risk reduction, you want to use an occlusive dressing. You want to cover the entire insertion site. You want to make sure, if you have a rate of infection in your hospital, that you are considering an antiseptic dressing, because we don't want to add more risk. And make sure that you're putting the dressings on appropriately, because they can also add a mechanical compromise to the dressing. So if you just change the dressing and all of a sudden, wow, your waveform isn't that great, please go back to the dressing. Assess what you did last to make sure that you put it on the right way, that it doesn't have a kink in the catheter now after the dressing, and always sort of work backwards in that mindset. So the dressing and securement, we do not suture, and we do not put things over the thumb. So please understand what your securement is and how you secure your catheters, that they don't dislodge. If you have leaking from the insertion site, check your catheter hub connection first at the exit site of the catheter. Verify that the patient has good coagulation status, or are we expecting bleeding, especially from the exit site of the catheter. If it's bleeding around the catheter where the catheter was inserted, we have to assume that the patient doesn't have great coags. We're going to hold pressure. We're going to change the dressing. Remember, we do not leave dirty dressings on the exit site, because that potentiates risk of infection. Exit site management and bleeding is very important, especially when you have patients who come in for a stroke and we give them a clot buster, and now they may have leaking and oozing from different sites. Catheter kinking, please consider inserting your catheter 2 to 3 centimeters proximal to the flexor crease, away from the wrist and away from the range of motion. This will really help with securement, but also catheter dwell. All right, so I think that ends a lot of information for you, and I'm glad you have this as a handout. Take some of these best practices back and just look to see what you're doing in your hospital. This activity has been approved, like Rita said, for 1 CRCE credit from AARC, California Board of Nursing, and the Florida Board of Nursing, and you will, at the end of the webinar, you can obtain those by logging into SACS communications directly on the link provided. I'm going to turn this back now to Rita for questions.
Amy, thank you so much. That was just a wealth of information, and we appreciate your expertise. We appreciate your time, and I know that it takes a lot of time and thought to put together a presentation like this. So we do have a couple questions. So let me start with Susan. It's a very interesting perspective and a point of view. So Susan asks, will you cover how infection prevention should be tackled with the respiratory therapists? Nursing sometimes is easier to work with, but RT folks are sometimes apprehensive in hearing suggestions from infection prevention people in my facility.
Oh, Susan, now you did see that I am a respiratory therapist, right? Education, and evidence, and structure, guideline, and remember that every discipline, regardless of who you are in the hospital, practices to the policy and the standard. So the first thing I would do is get the policy. What does the policy say? Make sure everybody is well educated about it. Don't leave anybody out when you're doing education and training. I have a lot of dynamic respiratory teams, and I have a lot of dynamic nursing teams, and the one thing that neither of those teams get enough of is education and collaboration. So ultrasound is changing the forefront of A-line insertion, and the requirement for the hat mask, small sterile drape, and probe cover should be utilized and monitored with a checklist, just like for CVC insertion. So I hope that helps.
Thanks, Amy. This from Arthella. Should the tubing connected to the art line be sterile? And should this sterile tubing be changed every 96 hours?
So, Arthella, thank you for the question. The tubing, if you dump the sterile tubing and the sterile one-way stopcock, remember, you cannot use a three-way stopcock, because if you do, if somebody can draw blood from it, it's no longer in that sterile opportunity. So you want a closed system by dumping the sterile 6-inch piece of tubing and the sterile stopcock onto your insertion field. You're going to connect those two pieces together. You're going to flush that system and attach it to your arterial catheter. You're going to place your sterile dressing over the catheter and over the tubing at the distal, where the connection is. Then you can safely connect your transducer tubing in an aseptic manner versus a sterile manner. That tubing only is required to be changed every 7 days when the dressing is changed because it was in a sterile manner, like the dressing.
Okay, thank you. Amy, for the next question comes from Jennifer, and it's, as I read through it, if I need to read through it twice, just please let me know. So Jennifer says, I have cared for patients post-neuro intervention who presented with a large French catheter who required an intra-arterial pump infusion of heparin to keep it open at a rate of 3 cc's per minute, which equals 180 cc's per hour. This was with a 1-to-1 heparin solution per the physician request. The question is, at what French size of catheter should we change from traditional pressure bag at 2 cc's an hour to intra-arterial pump, and at what rate? Did you get that, Amy, or do I need to repeat it?
No, I got it.
Okay.
So the way the pressure transducer is built today, you don't change it, and you would never change the concentration of heparin. And I would caution you to use that 1-to-1, only because 1, is it within your scope of practice? 2, is the patient coagulopathic? 3, are you covered under that practice? And that's we're walking a very fine line away from normal arterial pressure transducing, and it sounds like we're trying to treat an occlusion or an occurrence, and that is not the scope of this lecture, and that would be done through a totally different transducer setup. So mechanically, to change it to 3 cc's, I'd be interested to understand that. You can always email me directly, and I can try to help you find stuff. But the last thing I need to say to you is you practice safe. And if you're asked to do that, where is the policy that supports the practice? Because when something happens or something fails or there becomes an issue, it comes back to the provider that connected it, not the provider that ordered it. So please safeguard yourself and make sure you have a policy to support that practice.
Thank you, Amy. It is 1 minute after the hour. I'm going to entertain a few more questions with Amy, so we'll probably go over by 3 to 5 minutes. So I will continue with a few more questions. This is from Karen. In NIC ICU, I am seeing PALS, P-A-L-S, with a backup of blood behind the transducer. Can you address that, Amy?
Yeah. So Karen, you work in the nursery intensive care, and you're using the pediatric assembly, and you're having blood in the tubing. So the best thing, if I'm reading that correctly, the difference in NICU and in PICU, depending on the size of the patient, we take all that tubing off the transducer, and we really just use the transducer. And in the NICU, PICU area, we use the pump. So it's very important that once you do your blood draw, and I know that we volume restrict in those areas, so once you do your blood draw, that you do an adequate flushing. Where I caution you at is flush. We can't give an excessive flush because we're restricted to that. What's in the system is the patient's. So as long as it's not compromising the performance of the catheter or the transducer, you're okay to have that filament or see that sediment in the tubing slightly, because what's in the tubing is the patient's. So flush it as good as you can, and then I'm not going to say ignore the blood in the tubing, but if you're seeing like just like a residual of blood, that's okay. If you're seeing bright red thick blood that isn't flushing well, you have to think about the catheter performance. Is it keen? Can I flush it well after each blood draw?
Okay, thank you, Amy. This from Gail, a simple yes or no question for you this time, Amy. Can I use the handouts to prepare for a competency for registered nurses at work?
Absolutely. Absolutely. And I would encourage you, Gail, to also grab a transducer, grab a pole, grab an arm board, and really make it as hands-on as you can. Because the more hands-on you make it, the more they'll remember it. And the more they remember it, the more they'll do it. So use the handout, please, and also grab all of your necessary components, because arterial catheters are directly impacted by the things that we add to them. And you may add an interesting dressing, you may have different kinds of tubing, you might have a different arm board. So please bring all of that to the table when you do your hands-on education.
Thank you. And from Marie, if the head of the bed is to be maintained at 30 degrees for the VAP bundle, the VAP bundle, should the zeroing still be performed with the head of the bed flat?
Great question. You can actually do phlebostatic access up to 35 degrees. So you can do your 30-degree angle and do your phlebostatic access measurement. When the phlebostatic access is most inaccurate is when the patient's sitting up in a chair. So most likely we're not titrating meds and drips when the patient's sitting up in the chair. Sometimes in the ICU we like to put them in the chair position. So I use caution when they're over the 35 degrees. Flat is most perfect, but patients don't like to lay flat, and we understand that. So 35 degrees is perfect. Thanks for the question.
Okay. From Karina, do you recommend steri strips to anchor the line?
So as Karina, as you saw in the picture demonstrated, that was one of my arterial insertions. For many, many years we used steri strips and still do. Well, we don't use a suture, so we can use steri strips. They're in a sterile packaging, and they're placed once the catheter is inserted by the inserter, who is still in sterile gloves and sterile draping. You can also use a sutureless securement device. There's a lot of them on the market, and then there's also some dressings that have securement support within them that you can also use. So if you change something, if you add something, track your data behind that change so that you made a positive or a negative change in your practice.
Okay, Amy, I'm going to probably have this be the last question. So do the recommendations state to use femoral access for arterial blood pressure monitoring when sepsis is present? Doesn't femoral insertion site location increase the risk of infection? Amy?
That is, boy, I just got a slew of great questions today. All right, so we always say the rule is stool, and we don't like to go in the groin, but sometimes you have to. And if you think about your patient scenario, when you place an arterial catheter in the extremity in a shock patient who's clamped down peripherally, because that's what the body does, we give more medications to try to support a very low blood pressure. The only thing that's warm is the trunk. If we use the groin, the difference between inserting in the radial area and in the groin is as follows. 1, the radial is a small drape, sterile gloves, hat, and mask, and chlorhexidine prepping. In the groin, it's full barrier draping. Ultrasound, absolutely, you want to do that because you want to get outside the skin fold. So just like I said, you take 2 fingers to go down the wrist. I want you to take 3 fingers and get out of the skin fold. If you're inserting anywhere that's wet, moist, hairy, or shiny, you need to prep for 2 minutes with a 4-minute dry. You need to max barrier precautions with a full body drape. You need to probe cover with sterile donning and insert with ultrasound guidance so you only have 1 insertion attempt, reducing the number of sticks that increases risk of infection. But you're also going to monitor that line differently, like lots of observation, and put immediate antiseptic dressing or antimicrobial dressing on that site. That is the recommendation. So from a circulation point of view, that is a better practice than trying to chase a blood pressure in an extremity that's not correct, that's only adding risk to the extremity circulation. If you're really looking for a true trunk blood pressure, and you can see the patient I'm talking about, they're modeled, they're on vent, they are on blood pressure support with several pumps in the room, that is not a patient that we should be looking at a blood pressure in the wrist. We really should be going groin.
Amy, I thank you for all of the great information. And at this time, Emily, I'm going to turn this back over to you.
Okay, wow. Amy and Rita, it's always a pleasure working with you. I'd like to thank you very much for your time, and the material that you've covered with us today is so critical. And finally, I'd like to thank each and every one of you our guests in the live audience today, and as well those of you in a future time who are attending this recorded session. We thank you for your time and your thoughtful attention. And now this does conclude our session for today. Please take care, everyone, and bye for now. We'll see you again next time.